Okay, thanks again for everybody who's joined us today, and especially to Natalie Stewart with the Purdue Healthcare Advisors, who has put together this presentation for us today. Quick program over meaningful use. We appreciate her time. A couple quick housekeeping items. If you are on the phone today, we would appreciate it if you mute your line from your phone. I can do it on our end if we need to, but it does make things flow a bit more smoothly when you mute yourself. And then in the meantime, if anybody has any questions they would like to ask while muted, you can do so by taking your mouse and hovering at the bottom of the screen. There is a chat function that you can use there, and I will moderate questions for the end. So without further ado, Natalie, I'll turn it over to you.
Thank you, Allie, and thank you to the IRHA team for having me today. I am here to talk about meaningful use audits. And as you see, as we go through these slides, a lot of this is going to cover both hospital and ambulatory EPs, and it's a lot of the same information is going to be required. So when I say the word provider, that's the all-encompassing word for EPs and eligible hospitals and critical access hospitals. If I've called out specifically EPs and or EHs or CAHs, then that's because I am referring to those individually, or maybe I just didn't use the word provider for repetition. But if something applies only to EPs or only to hospitals, I will have that specifically called out. So just a quick little nomenclature note before we jump in. And before we jump into the audit discussion, I would be remiss if I did not remind anybody on the line that if you have 2015 meaningful use for Medicaid to submit, we've been on hold. That's kind of been paused for the year as MAPR underwent the upgrade. But MAPR, the attestation portal, is now open, and so please submit any and all of your program year 2015 meaningful use and AIU applications before September 12th, because once that deadline hits, no longer will 2012 applications be accepted. Please note that you can submit a program year 2016 application, but that is only for AIU at this point. As far as I'm aware, in meaningful use, MU applications are not yet being accepted if you are doing a 90-day time frame in 2016 as a first-year participant. And likewise, just one last reminder, shameless reminder, that 2016 is the last year to begin the Medicaid EHR incentive program. So all providers, and I've called out specifically EPs here, but if there are some hospitals out there, if you're planning to participate in Medicaid meaningful use, you must have enrolled and done your first participation year by 2016. There is no starting later in 2017. So just a quick reminder, a couple of reminders off the top here before we jump into audits. But back to our audits, because that's the real discussion of what we're talking about today. If you are participating in the meaningful use program, whether it be Medicare or Medicaid, you may be subject to an audit. And you can be audited more than once. In fact, you can be audited every year you participate. I am not aware, anecdotally, of anybody who's actually been audited every single year, but it is one of those things where it's, as I've heard somebody say, in another webinar, it's not if you're going to be audited, it's when. So what is the purpose of doing this? It's not, believe it or not, to create stress and anxiety. It is mandated. It's part of the statute for meaningful use, and it provides a checks and balances. And it's not only to ensure that there's no fraud or anything like that, but it's to ensure the program integrity, because this is money flowing through CMS, tax dollars. So there's a duty to the taxpayers that this program is run with integrity and has a checks and balances system in place. Depending on the program which you are participating, it does not matter which provider. Medicare has a certain company that they've contracted with. CMS has contracted with Figliozzi and Company to perform any meaningful use audits that are submitted. Each state will administer their Medicaid meaningful use audits, and for the state of Indiana, those are completed by Myers and Stauffer. So there are some program differences between the two meaningful use program audit programs, but you'll see that they're actually pretty similar in terms of process. So you can see a comparison here. Of course, we're looking at Indiana Medicaid because that's what the majority of us are participating in. Please note, if you do have some providers who participate in other state Medicaids, so perhaps you're on the border and you have providers that are submitting meaningful use to Illinois Medicaid, Kentucky Medicaid, Ohio, et cetera, they will have a different, likely have a different organization performing those audits and may have a different process. So we're looking strictly at the Indiana Medicaid process when we talk Medicaid. So for Medicaid, they're administered by FSSA, and FSSA works with a group called Myers and Stauffer to perform both prepayment validation and post-payment audits. Likewise, Medicare, or CMS, has contracted with Figliozzi and Company to perform prepayment validation and post-payment audits. So let's look at Medicare first. Those are just inherently, because of the Medicare Meaningful Use Program, they seem a little more straightforward than the states. So looking at CMS Medicare and that process, it's a fairly straightforward process. You're going to get an initial request letter from cms.gov, and it's going to come via certified letter, and you may, not all the time, but you may get an email as well. And the email is going to go to the contact that you specified during registration for meaningful use. So just as a quick note, when you go in to do meaningful use attestation, it behooves you to update that registration if the person has left the organization, or if it's a person who maybe is still with the organization but their email address has changed, or they don't regularly check their email address, because this will be how Figliozzi will try to get a hold of you. So you may want to check that, make sure that your contact person is updated. The letter is going to specify the type of review and the documentation requested. So they're going to let you know which program year they're looking at, and they're going to let you know what information they want, and they will give you a specific time frame to provide that data, and it's typically 2 weeks from the date of the letter. So again, that goes back to why it's so important to keep that contact information updated in registration, because they will try, you know, that 2 weeks can get eaten into if Figliozzi is trying to get a hold of you. And you may have to work with them to get an extension or request an extension to provide, to have longer to submit that data. The auditors, once you have the data and you've submitted it, the auditors are going to review that documentation. They will request information from you if additional clarification is needed, but they will give you a final response sent via email. How are you selected? So there's, as we said, prepayment validation and post-payment audits. Prepayment, sometimes those go on behind the scenes and you're not aware of it. That can go by looking at eligibility verification. So for instance, if you have submitted data and you know, your taxonomy code, or you're listed as a hospital-based provider, they may come back and say, ooh, you may not need to be submitting this data, or we have you in a different classification, so they'll contact you that way. It could be a random review. Again, you may not know that it's going on behind the scenes. There are red flag reviews and targeting suspicious data, and when they say suspicious data, it's not always indicative of malicious intent. For instance, one of the more common, and I'm saying this in quotes, suspicious data items is there are certain objectives, the percentage-based objectives, where the denominator should be the same across many denominators. So if you, and this is becoming less so, it used to be a lot easier to describe this when we had the objective of demographics, meaningful use demographics back in those days. The demographics denominator was the total unique patients seen by the provider during the reporting period. Likewise, the med list, problem list, and medication allergy list objectives, their denominators were the exact same. So when they say targeting suspicious data, they would expect to see that the denominator for all 4 of those objectives would be exactly the same because it's exactly the same criteria. So if you submit a denominator of 100 for the med, problem, and medication allergy list objectives, and then 347 for your demographics objective, they're going to take a look at that and be like, ooh, that seems a little suspicious to us. What happened? And they may contact you. And then again, for prepayment, it is exactly what it is. If you are selected for one of those, you must validate that data before you can receive your incentive payment. It's becoming less so now because a lot of folks who have participated in the Medicare Meaningful Use program have aged out of the incentives. Used to, they would hold on to the incentive payment until the audit was clear or the validation was cleared. And that will still continue for anyone who has meaningful use incentives to collect for this year. However, most likely it will be some sort of post-payment audit moving forward. And looking at the post-payment audits, again, it's a lot of the same kind of criteria, the random reviews where you just get the luck of the draw, those red flag reviews that are looking at suspicious data, fraud identification. So it can be, going back to targeting suspicious data, it can be and is used to identify fraudulent documentation or fraudulent attestations and root out those types of issues. And then, of course, data validation. How will you know if you've received a notice of audit from CMS? You're going to get a letter, and it may be attached in an email. It will be in certified mail as well. And here is a copy or a sample of what it will look like. And this is provided by CMS. So it's a quick letter. It's going to have the CMS and EHR logos on it and Figliozzi on it as well. The letter will come to you from Figliozzi. It's not from CMS because they are working on behalf of CMS, but they will have the logo. Moving over to Indiana Medicaid, because this is where it gets a little fun because there's so much that goes into this. So likewise, the process is similar to CMS. You're going to get an initial request letter from FSSA, and it's going to be sent via certified letter and or email, and it's going to be to the contact that was specified in your attestation. So you have to register with CMS and then go to the MAPR application within Web Interchange, and in that application for each year, that's where you specify a contact person. So of course you want to update that. And what they'll do is if it's a previous attestation and somebody has left the organization or is no longer the contact person, they will look back at the registration. So going back to the CMS discussion, when you register, you may want to update that as often as you can. They do have other ways of trying to get a hold of you. They will contact the office. They will contact who they have in the Medicaid files, so to speak, as the contact person for the organization. But again, it helps out everyone if that contact information is updated as often as it possibly can. The letter is going to specify, again, the type of review and the documentation that they request. Now, here's where a little thing is a little different. The majority of the reviews are going to be desk reviews, meaning that FSSA requests certain information from you and you provide it electronically, and then they review it and let you know. There are, and they do reserve the right to do on-site reviews or field audits, and they have done those in the past. I'm not aware of anecdotally of any that have been going on recently within like the last year, but they have been done, and I'm sure will continue to be done as needed. Again, like CMS, the FSSA process is very similar. The auditors are going to review the documentation that you supplied, and they'll request additional information if clarification is needed. Then they're going to send you a final response, and it will be in an email, but there's also going to be a letter that's sent. How are providers selected? You may not realize this, but every provider, be it hospital or eligible professional, are participating in a prepayment validation. When you go into a test in Mapper, you are required to upload specific pieces of documentation. And if you have not provided that documentation, you will get a friendly email from the HPE folks who are helping with this to upload certain pieces of documentation. That is because they are doing a prepayment validation on all attestations prior to issuing incentive payments. So all providers who attest in Mapper are required to upload documentation prior to having their attestation processed. And if they do need additional information, HP is going to reach out to you. So again, make sure that contact person is updated. So you may not have realized that. It may have been frustrating that you have to go in and upload additional information before submitting, but that is actually your participation in the prepayment validation process. And that information is required before they will begin processing any meaningful use applications or AIU applications for payment. Post-payment audits for EPs, and this is similar for hospitals, but this is more geared toward the EPs. Audit team from Myers and Stauffer receives a list of all providers who were paid during the applicable review period, and all paid claims will be queried for each provider that received the payment, and then compared against the attestations and prepayment review results. And then each provider is placed in one of 4 risk categories. And then from each of those 4 categories, a sample size is selected for audit. I don't know what that sample size is. I can't, I unfortunately can't give any kind of, clue as to, well, it's only 5 providers out of each category or blah. I have no idea how many providers are in each sample size or what the 4 risk categories, the thresholds between the each are. But in terms of process, this is how it happens. And so going back, to this slide, why I specifically call out EPs is because moving on to talking about how you're selected, for AIU, all AIU applications go through a desk review. It's almost essentially, it's a 100% of AIU applications are going through prepayment validation. And again, because they're doing the prepayment and looking at the documents that you're uploading, you don't realize that you're being selected for an audit, so there's no notification that comes to you. You only get notified if there additional documentation is needed, again, through the email process with HPE. Moving over to meaningful use, as I mentioned on the previous slide, that's the process for EPs. It is assumed that that is similar for hospitals, and why I say it is assumed is because FSSA is great about publishing their process and that sort of thing in regards. They have tons of FAQs, and it's really a great resource. They don't address hospitals directly in terms of meaningful use audits, and anecdotally, I don't know of any hospital that I have worked with, or that we, meaning Purdue, have worked with in the state who've undergone a meaningful use audit. That doesn't mean that they wouldn't or that they can't. It just means that we're not aware of anyone who has, so I can't speak from personal experience of how that audit process looks. It is assumed that it would look similar to the eligible professional. So that's why on that previous slide I called out eligible professionals only. But again, you're going to be notified via certified letter and probably email. The letter is going to include the detailed information they're requesting. As we said before, the audits are most likely, in the majority, are going to be desk audits, but on-site audits could be requested. And any selected providers or hospitals would be notified via letter of the audit findings. A desk audit, again, it's that remote audit. There are, oh, I'm sorry, that's a typo. That should say field audit, a field audit. So if you were ever selected for a field audit, it's a two-part review on site. The first part, they're going to look at understanding your EHR workflow and discussing, they're going to want to talk with people who are knowledgeable about the system, probably your system and IT coordinators, your super users, that sort of thing, on how data entry is happening during normal workflows. And then they will want to test and validate the use of the system, either by watching you, seeing it in action, so to speak. The second part is going to be a detailed review of documentation and source information. So they're going to ask before their arrival for detailed info from a sample of the selected measures that they're attesting. So they may say, I want to see 10 charts, for example, out of the patients who fell in the numerator for the CPOE medication orders objective. And then they will come on arrival and perform that workflow to confirm that the information is in the EHR. Again, this is, we know of a few folks that we work with who've had these field audits, and it does take, depending on the number of providers, it can take a couple of days. So it is something that you'd probably need to coordinate some folks from your team into the same room and work directly with the provider, or I'm sorry, the auditors. How will you know if you've received an audit from FSSA? You will get a letter. It will come via certified mail, and it will not it will not have Myers and Stauffer big logo on there. It's going to have the FSSA logo on there. This is a sample of a real audit letter. So you can see how it's going to look. Of course, the information is blocked out there, but it's going to have the date, the address that it's sent to, the provider's NPI, and their name. And it's going to provide a list of the information that they're looking at. Most likely, they're going to want additional information that was not already provided when you attested. So final determination, that process is similar across both programs. You will receive an audit response, and it will tell you that the determination was that you have met the criteria or that you have not met the criteria. They will not provide you a scoring matrix, so to speak. For instance, they're not going to say, what they determined or how they determined that you did not fulfill that. They will say, due to, you did not pass due to, not meeting this objective or something like that, but they're not going to go into specifics from the Medicare standpoint. From the Medicaid standpoint, they will. So if an audit is passed, you of course will get that notification, but you may not get an official letter. But if you have not passed that, or if you have failed, you will get a letter that will explain to you why. So, you did not meet the 30% Medicaid eligibility criteria, you did not meet the the threshold for the objective, et cetera. And that will give you a demand letter, and it will have repayment instructions and appeals rights. That is the final determination letter. So what that looks like from the FSSA standpoint, again, from personal experience, I have not worked with any providers who have failed a CMS audit. However, the process for FSSA is that you will actually get a preliminary or draft audit finding via certified mail. So that means that the audit findings are not official at that point. So if you are a Medicaid provider and it has been determined that you have failed the audit, or in other words, an overpayment of meaningful use funds has been identified, you will receive a draft audit finding. And that draft audit finding will tell you why they have identified that you as the provider or hospital is going to potentially fail to meet the program requirements. And that letter is going to outline to you that you have the opportunity to respond with a request for administrative review within 45 days. Once that 45 days passes, whether you have not requested for administrative review or you have forfeited administrative review, because they will ask you to return a form that says you plan to go for administrative review and thus request it, that you forfeit that, or that you want an administrative review within the 45 days. Once that time frame has passed, if an overpayment is still found, so if it was found that you still are not meeting the meaningful use requirements, you will get a final audit finding letter via certified mail, and they will include instructions on how to respond to the findings, and it will have a final calculation of the overpayment of funds that they found, and then per Indiana code, you have 300 days to repay the specified amount. And that is regardless of whether you choose to appeal the findings or not. So again, administrative review is not an appeal because those findings are in draft format. When you get the final audit finding, those are final and thus subject to appeal. However, if you do choose to go for an appeal, that is absolutely fine. However, you are still required to begin the process to repaying the amount because the appeal could last longer than the 300 days, and you would not want to go into like a collections or past due situation. Now, if you were to win that appeal, there could be a reissuing of the payment. I, again, am not aware of any situation where that has happened, but per the Indiana code, this is how the process should work. So that was a look at the process, but let's talk about why do people or providers fail audits. So the first and foremost, the most common situation is the privacy and security objective and the security risk assessment. There's a variety of reasons, but the most common reasons are first and foremost that it just was not completed at all, whether because you forgot or because there was an assumption that my vendor was going to take care of it, but no documentation exists and there is no indication that a security risk assessment was ever completed. Another option or another reason for not meeting the security risk assessment objective is that you used a checklist. CMS, the Office of Civil Rights, which overlooks HIPAA, and ONC, from the perspective of meaningful use, have all said that checklists are not equated to a robust security risk assessment. As we talked about on the webinar last week about meaningful use objectives in 2016, the security risk assessment and the privacy and security objective is something that CMS and OCR take very, very seriously. And therefore, there is no exclusion to this objective. There is no conceivable reason why it would be acceptable that this objective was not taken care of. So using a checklist is not considered the same as doing a security risk assessment. Or the last most common reason is that maybe you actually did do a security risk assessment. However, there is no documentation that exists. There's no report, nothing can be found, or we can find the report, but we can't find that anything was documented to show that you made progress in trying to mitigate any kind of identified deficiencies. Again, this is a living, breathing document. It's not a one and done, which is hence why checklists are not acceptable. So that when things are identified, you are wanting to incorporate that into your risk management process and thus keep updating it as you make progress toward mitigating certain or the identified issues. So again, this is not, we did it on August 23rd and we're not going to look at it again. We're going to, pack it away in a box and never look at it again. You want to update it as you make progress. So that is another common reason why a security risk assessment would cause you, even if you have done it, to not meet the objective. Likewise, my vendor or consultant said it was okay. That's great, but if you have done something based on the advice or guidance from a CMS FAQ or a consultant or vendor, substantiate any of that advice that was given and maintain documentation and written documentation. I kind of cringe because I know sometimes I send out emails to folks who ask questions that are probably way too long and way too technical, or that have way too long citations from final rules and FAQs, and I acknowledge that, but it's because I want you to have the reasoning behind why I've answered your question this way. So any consultant or any vendor who gives you recommendations, if they may be the correct information or the most accurate information at the time, but you want to substantiate that, have the FAQ save it. Even if you're, typing out a Word document with a narrative of why you chose to do this, and then, reference this citation from the final rule or this FAQ. Another reason why it's great and actually is best practice to have, save any FAQs or any kind of CMS tip sheets or anything that have that you use as evidence of why you chose to interpret something this way is because things change over the years. As we know, the version of stage 1 meaningful use from 2012 is not the same as stage 1 meaningful use today. So if you are being audited for 2012, FAQs can go away, FAQs can be updated, and so, FAQ number 5 may not look the same as it did back in 2012. So you want to save things per year and save them as they were at that time, because it's hard to go back and recreate or find things that are no longer available. CMS does retract some FAQs if they're no longer applicable or if something has been updated. So if one FAQ updates a previous FAQ, it may, they may pull down that FAQ and you won't be able to find it because it's no longer even searchable. The next reason, lack of ownership of a complete EHR. This is particularly common, more so in the EP world than it is in the hospital world. And it's actually kind of odd to me because the hospital world, folks tend to have more modular type systems. Whereas in the ambulatory world, EPs have more complete systems. But any time that you're in a situation where you own a part or a piece of a complete EHR product and then you use another piece of a complete EHR product. Anytime you're starting to mix and match certain functionalities from different vendors or different products, you want to make sure that you have, when all is said and done, a complete EHR, and that you're not using non-certified software to meet any of the meaningful use objectives, because the requirement is that you are using certified EHR technology to meet meaningful use objectives. One example that I have seen is it was with Public Health Registry, and years and years ago, they had purchased an additional module to submit public health data, and then the intent was good, to submit that public health data, but the module was not certified. So you just want to make sure that you have it, once you start mixing and matching pieces and parts of EHR systems, that you, when all is said and done, have a complete system. This one can be very common, the reports lacking identification, especially for EPs, because there's so many EPs. Your reports lack identification of the provider name and who it was, or the EHR. So one of the more frustrating things is that a lot of auditors are requesting that when you send the reports that you have a vendor name and logo on it, you have the EP's name on it that identifies it. If you're in a hospital system where you have multiple hospitals, likewise, you would do this. But what is frustrating is that in the early years of meaningful use, a lot of EHR vendors had just basic Excel spreadsheets that didn't have any identification information on it in terms of the vendor's name, its logo, anything. So what's become frustrating is that, being audited for previous years, it's becoming difficult to provide reports that have those names and logos on them. If you have situations like that, there are ways to remedy that. First and foremost, communicating to the vendor, or I'm sorry, to the auditor. But we'll talk about in a little bit what you can do if you still have one of those systems that provides reports in Excel spreadsheets or generic notepad-looking forms. The public health objectives, again, similar to the security risk assessment, you may have completed it, but you didn't save adequate documentation. You may have thought that the vendor took care of it. Any time around that with the public health objectives and not having documentation is a situation that's cause for concern. So what can you do? I had to throw out my little, I'm a child of the Disney movies of a kid and be prepared here. I'm thinking Scar singing as I talk about this. Be organized and prepared. Generate the documentation as you go. We kind of touched on this earlier. You can't go back and recreate dates and timeframes, especially after software upgrades or patches. A lot of EHR systems, especially when we went from 2011 certified edition to 2014, the look and feel of the system changed. So not only did reports probably get updated as stage 1 turned into stage 2, and now we have modified stage 2. A lot of the reports and the availability of reports are going away, so or changing. So it's becoming especially difficult to go back and recreate reports. For instance, if you're audited for a stage 1 meaningful use attestation in 2012, if you were trying to recreate a report from there and it was for the clinical visit summary, that's not an objective anymore for EPs. So it's going to be virtually impossible to recreate that report. So the best advice is generate that documentation as you go. Have an audit response plan, even if it's something as simple as this is the designated person, or all documentation is going to be saved in this area electronically and in paper format. Something as simple as that that can help alleviate some of that anxiety. Or if, if anybody on the call has been in the position where somebody took care of it, in previous years and now you own it, trying to understand or find where that documentation is, thinking through thought processes and that sort of thing, making sure that you have a plan of how, who is going to react, how you're going to save it, where you're going to save it, that sort of thing. Have an attestation documentation packet. I'm going down to my call out below there, especially for EPs. Remember, the audits are performed on a per NPI basis, so per EP. You want to keep all of your documentation on a per EP basis. And if you have group documentation, such as public health confirmation, the security risk assessment, specifically label that this, this security risk assessment applies to these providers, provider A, B, C, D, and call out their names. That way that there's no question in years later that this was applicable to this provider at that time. And then keep your evidence packet with regards to software screenshots. For Medicaid, they want you to upload a screenshot of the version of the EHR that you use, which is typically that first login screen. If you have any documented workflows, that just has further support of how, what the standard procedure is for how how data is documented into the EHR. How do you prepare? Remember that every year of attestation that you submit is auditable for up to 6 years after that year. So you want to keep documentation submitted for each attestation for a minimum of 6 years. So once if you submit data, meaningful use data for 2016, it can be audited for up to 6 years after that. Likewise for all previous attestation years. Remember, I think I've beat this pretty hard today, but notifications are sent to the contact person designated during your registration for CMS, Medicare, or attestation for Medicaid. So you want to make sure you update that contact person as needed each year. Commonly requested documents that we've heard about or that we've been able to help folks with, seeing what's requested on letters, proof of certified EHR technology for that reporting period. So they're going to want a copy of the ONC authorized certified testing body, certification number, and a screenshot of the version that you were using to show that they correspond. They also could potentially ask in the case of Medicaid, they will ask for proof of purchase, a licensing agreement, vendor invoices, anything that shows that you have a financially or contractually based agreement with a vendor that shows that you are getting updates, that you are continuing to use a certified version of that technology. This goes for both programs, metrics reports for all attested measures. They preferably should be system-generated reports, and they should have the reporting dates, the vendor name and logo, and the provider name on the report. And then it would show the numerator and denominator for all of your percentage-based meaningful use measures. For your CQMs, not only will they show the numerator and denominator, but make sure your reports show the exclusions and exemptions because that is something that's required for a vendor to produce. And from experience, it's not so much anymore, but in the early days of meaningful use, there were some vendors who did not put exclusions and exemptions on their reports for CQMs. So you just want to make sure that your report does have that, or you may be looking at one version of the report and there's a more detailed version that you can get. If your reports don't have the vendor's name or logo on it, Be sure that you document screenshots of the step-by-step process of how you generated those reports so that you can show that the end result, that is a generic Excel spreadsheet or a generic notepad looking report, is what you get when you go through the steps to generate those reports. The next, making sure that you have your security risk assessment report, but then you have your management plan that you are updating, and making sure that you at least have links or know where any kind of related policies and procedures are, if they are referenced in the SRA report, particularly if it was noted that a policy was not in place. So for instance, if it was recommended that you have a password reset policy that, you know, users have to update their passwords every 90 days, if that was a policy that you have since created, make sure you have a link to that or save a copy of it so you can show, yes, we did address this. Other documentation, particularly for Medicaid, you will be asked for this. I want to say I guarantee it, but of course I can't guarantee it. But most commonly, you will be asked for this information. Documentation that more than 50% of your encounters occurred at a location equipped with certified EHR technology, and likewise that more than 80% of your unique patient records are maintained in certified EHR. Confirmation of public health objective completion. Preferably, this would be in the form of a ISDH letter, a letter with the Indiana State Department of Health seal on it. ISDH actually has a great website. It's a self-service website where you can go in and you know, put your information in for your meaningful use objective for each year. And you can print out a letter, and then later on, if you ever needed that letter again, you can go back into that account and reprint that letter on demand. So it's kind of a nice function if you do happen to misplace that letter or not know where it is or forgot to print it before. And then screenshots of your enabled clinical decision support, drug-to-drug, drug allergy interaction checks. Again, the requirement for those are that they are enabled the entire reporting period, but you do want to have screenshots that they are actually enabled. And then if, you know, if there's not a way for you to demonstrate that they were enabled the entire time, you could have a policy or something from the vendor's manual or something that says, look, this is a functionality that nobody here has the ability to adjust, or, you know, only 2 people in the entire organization have the ability to do this, and they attest that they did not change this, they did not turn this off. One thing that's become very nice is a few vendors, I'll call out Allscripts particularly because they were the first one that I was aware of that did this. I believe Athena Health does this as well. They actually have a report that you can run that shows the day that these functionalities, the clinical decision support and drug allergy checks were enabled, and shows that they've never been disabled, or if they have, what day it was, so that you have additional supportive documentation that shows that these functionalities were enabled the entire reporting period. For Medicaid participants only, because you have the eligibility requirement of more than 30% of Medicaid volume, you will have to also save volume reports. You want to save both summary and detailed reports of how you arrived at that volume data, whether it, you know, indicate whether it was from a group proxy level or individual level. The detailed reports should show the dates of service, the payer type, somehow identify the patient either by an ID number from the system or their name, the provider's location and name or NPI somehow to identify the provider. If you used out-of-state Medicaid encounters, that's absolutely great, but you want to be able to, you want to also have that saved, that data saved, because they will have to compare that to the Indiana volume that they have. If you're an SQHC or a rural health center, of course, you have the added needy patient encounter volume that you can include, and you want to save the needy patient encounter data just like you would for the Medicaid patients. And then, of course, that's all for your numerator. For your denominator, you want to save the exact same thing for all patients, regardless of payer type that you're using. One question that FSSA has addressed, and we've gotten it quite a bit, is that's some pretty hefty data that the auditors would request or are requesting. Isn't it against HIPAA regulation to send this kind of information? And in short, this is a small snapshot of a much larger explanation, and I've linked to the actual FAQ there, but in short, no, it's not a violation. The detailed information does not ask for specific PHI, identifiable PHI information, such as, you know, the chief complaint, other things for the patients that would identify from, you know, as a self-pay patient or something like that, why they were there. So that FAQ, you know, again, I provided the short version, but this FAQ will go into why it's acceptable to respond to this request. So how do you work with auditors? Of course, being organized and timely, de-identify patient information unless it's specifically requested, hence right here, Medicaid volume reports. Provide only the information that's requested by the audit letter. And that's because, I mean, that helps simplify the process, because that way the auditors aren't looking through information that they have not requested, trying to figure out, why was this sent to me? Why is this information, why does this pertain to this? It just keeps it all simplified. If you do have questions, ask. If you need clarification or if you're just not sure, ask. Communicate the barriers, any kind of timing issues or other potential problems. Particularly, again, we have more experience with the Indiana Medicaid audit process. The auditors are very understanding, and they're very easy to work with, and are generally able to provide additional assistance or additional recommendations for, okay, if you don't have this, do you have this? Or if you do need an extension, they will be able to grant that. So they're very great about, you know, working with you and helping you be successful in the audit. Likewise, I mean, it's a small amount of experience, but likewise for Medicare, the Figliozzi group, the clients that I've worked with who've been through those and had to communicate issues to the Figliozzi group, they've been very responsive, very understanding, and you know, actually appreciate knowing about potential barriers ahead of time rather than at the 11th hour of waiting for the information. So your auditor is your friend. Make sure that you communicate any kind of information that could potentially, you know, indicate a problem or an issue. And in summary, being prepared is going to save everyone headaches and stress. Just inherently, the word audit, I think, can be an anxiety inducer, and I know it would be for me. But the purpose is not for it to be that way, and so how can we make that better? You know, saving our documentation, making sure things are labeled, and you know, so that we're prepared when it does happen. It can save everyone some stress and anxiety. Remember that you can be audited for up to 6 years, and the information must be supplied per provider. This, again, is particularly important for the ambulatory eligible professional groups, but if, you know, any hospitals that are on the line, if you're part of an organization that has multiple hospitals, this would likewise go for you. Again, being organized and responsive is going to make it a smooth process for everyone, both you and the auditors, which is great. And then if you have any questions, contact PHA. We have a help desk specifically to help providers for when things pop up, especially like with audits. If you have questions about, what could this potentially mean? Should I contact the auditor? What do I do in this situation? We're happy to help. And then lastly, here are some links that you can see. Again, you can see the attestation documentation requirements that are required for prepayment validation for Medicaid, the total FAQ list that they have, and then their audit guidelines. Likewise for Medicare, they have some sample letters. They have general information regarding, what supporting documentation to keep, that sort of thing. So those are all great resources. Lastly, if you need more assistance, particularly if you are participating in a FQHC, rural health center, community mental health center, community health clinic, critical access hospital, and Indiana Medicaid, contact us because we have grant funding available through FSSA to help providers, not only with audits, but with meaningful use in general. And so we would be happy to talk to you. My colleague Wayne handles all of the enrollment, so feel free to contact him if you have any questions or you want to see if you qualify for this program. Lastly, there's my contact information and our help desk. You can save that help desk number and email address and reach out to us. We're open every day, except for university designated holidays. But with that, I will turn it back over to Allie for closing comments and if there are any questions. But before I do that, again, thank you for having me today. Always appreciate the chance to talk with everyone and work with Indiana Rural Health Association.